Countries that were far ahead of us in palliative care many years actually don't have any better representation in terms of availability of morphine and its other derivatives. And that was surprising a lot. Secondly, I also say that some countries didn't have morphine or codeine, but they actually had fentanyl patches, and you really wonder who's making these policies and these decisions. And that was quite surprising to me. The implications for clinical practice are that we feel very, I'll say, inadequate as oncologists because we don't have the tools to prevent suffering at the end of life. We are educated as much as any other person is, but because of government legislation and shortages and all kinds of cultural beliefs, we can't really give our patients the best. It also translates into teaching because these drugs are not available. You can't teach your students also about how to use them appropriately. So it goes a long way. Actually, it's a very depressing picture, I must say. For patients, it means we are disappointing them and they're going to suffer. They say, well, how am I going to die? And what are you going to say? Because you know that you don't have the tools to curb this and improve their quality of lives, even at the end. So for patients, it's not a good thing. It's quite depressing, I must say. The main barriers are, one, I'll say, is cultural, because our health ministers, our doctors, our health professionals still are kind of afraid of morphine addiction. That is actually the main barrier. It has nothing to do with costs. And it also reflects in cultural practices as well, because once you're morphine, it means it's the end of life and you're dying. So they rather pretend not to have pain and not be prescribed morphine. It's very, difficult.